This week on the BackTable podcast.
I think a lot of us got into PAD, myself included. One of the reasons I like it so much is I like the absolution of it. With aorta, a patient comes in with an aneurysm, they don't even know they have it. Then I tell them they have this horrible thing and I fix it, but they never felt bad. With PAD, you got people who are like decrepit and lives are being ruined. You fix it, their wound heals, and they get their lives back. And I want to continue to do that. But because the patients are getting sicker, it's getting harder to get to that point nowadays. And so I would say to those people, don't lose hope, join forces, and let's do it. Like, what are we talking about? Let's do it.
The AMBITION BTK study is sponsored by AngioDynamics. Visit angiodynamics.com for product risk information.
Peripheral artery disease can show up in many ways, making it tough to choose the right treatment for every patient. But the Aurion system from AngioDynamics is changing that. Powered by advanced solid-state laser technology, Aurion is designed to treat a wide range of arterial disease: PAD, ISR, CLI, and even ALI, above or below the knee. With femoral, pedal, and now radial access via the new XL 225cm catheter, it's one of the most versatile tools in your lab. And unlike other lasers, Aurion's 355 nanometer wavelength and ultra-short 25 nanosecond pulse deliver precise, controlled energy, preserving healthy vessel walls while targeting tough lesions. That's science in action. It's no wonder why over 100,000 patients have been treated with Aurion over the last 5 years, and why more interventionalists are choosing it to help improve both limbs and lives. To learn more, visit aurion-system.com.
I'm your host, Sabeen, and today we're exploring a relentless topic that's been at the center of limb salvage conversations: atherectomy. It's a procedure we're all familiar with, but how strong is the data behind it, especially below the knee? Joining me is Anahita Dua, a vascular surgeon from Mass General who is a powerhouse. She is a principal investigator of the new AMBITION trial, a first-of-its-kind randomized controlled trial comparing below-the-knee atherectomy to angioplasty alone. We're going to talk evidence, past, present, and what's on the horizon. We're going to challenge dogma, talk design, and explore, finally, is atherectomy getting the data it needs to be a more definitive place in our toolkit. So welcome, Anahita. Welcome back to BackTable.
Thank you for having me. I'm thrilled to be here.
Thank you. Thank you. So I'm trying something new, and we'll see if this works, but I'm going to kind of throw out a question to you to think about, while we're talking about our topic today, and I'll ask it to you again at the end of the podcast. All right. And this is also for the listeners too. So my question to you is, what is the most overrated and what is the most underrated device in your tibial toolkit? So we'll answer those questions when we come back. But, beginning, just tell us a little bit about yourself. I know you've been on BackTable before, but for all our listeners right now, you're at the ultimate, Mass General. How did you get there? How did that happen? And what is kind of your practice like? And just tell us more about yourself.
Of course. Thank you so much. So I did my general surgery residency at the Medical College of Wisconsin and a postdoctoral research fellowship, really looking at coagulation, thrombosis, and stenosis, basically. And then I went to Stanford for my vascular surgery fellowship 7 years ago, graduated from Stanford, and then coming to Mass General actually was my first job, which I love the place. I always wanted to be somewhere where we could do everything and everyone gets to do everything. I'm not a niche girl, I want to just be able to do everything, complex aorta, that's complex awesome. PAD, veins, TOS, whatever. And so Mass General afforded all of that. And so I went and started there. And my practice, though, primarily, I would say 80% of what I do is complex PAD. I do a lot of deep venous arterialization, and really, I tell my patients, my practice is keeping your leg attached to your body. That's my job. And whatever it takes, that's what we're going to make happen. And so on the other side, I also run a NIH-funded lab that specifically looks at personalizing blood thinner because, as you know, Sabeen, also you being in IR, we do a 6-hour procedure. We're high-fiving at the end with the angio, but then who cares? At the end of the day, the wound has to heal 200 days later. And if your anticoagulation sucks, it goes down and ultimately you end up amping just 6 months later than you would have. So we figured that out a little bit. And so maybe another episode sometime I'll tell you a bit about that RCT that we're running right now on that.
I know. I may have to ask you some questions on that.
Oh,
That's
bring it.
great. Yeah. But that's great. I'm actually going to steal that line. Keeping your leg attached to your body is my job. I like
Keep
that.
it simple.
I think that's the. I think my patients will get that too. So I like that. So okay. So like I said in our intro, and I asked you I confirmed before even we started recording, I was like, is this really, the only trial that's a randomized controlled trial comparing atherectomy to angioplasty alone? I mean, that's a lot. That's a lot to get into. I mean, before we even get into that, I mean, what is the current state of evidence, for atherectomy below the knee, and how did we get there?
There is evidence, but they're not randomized controlled trials, to your point. And what has happened is, while there is evidence, we use the word atherectomy, and it encompasses so many different types of things. Like, atherectomy is an action of, basically drilling or lasering or in some form removing the plaque in order to get through and through access and then being able to treat. But as I mentioned, it comes in many different forms. So even if we say, does, quote, atherectomy work? Honestly, since you have so many different ways of doing it, you really have to test out each one if you're really going to be scientific about it. And I think what has happened in this particular realm is, as we all know, you being in IR, obviously, and our cardiology colleagues, myself in vascular surgery, there's been a lot of drama associated with the word. In some circles, it's a bad word not because of atherectomy itself, and this is what the problem is, not because of atherectomy itself, but because of, frankly, what is being termed as overuse, right? I mean, we have a healthcare system that we all work in, and there are some people, not specialty specific, but some people that are a little bad actors that have been overusing all kinds of things, not just atherectomy, but atherectomy reimbursed decently. And so that's what got kind of the focus. And ultimately what that led to was a little bit of, group warfare, kind of gang violence between the groups that deal with PAD. And so we say, atherectomy has more of a spotlight on it now, and we have to get the data, get the evidence, which is true. But if you look at other things, whatever, IVUS, drug-coated balloons, whatever you want to name off, all these other things that we use in the space, they aren't necessarily held to the same aggressive standard because they're not bad words. And so I'm not saying that overuse doesn't happen. Of course it happens. And I'm not saying that, the conversation around it shouldn't happen. But I think atherectomy has been unfairly targeted because, and we sort of are now using it interchangeably when what we actually mean is we want evidence about where it fits. I don't think anybody, when you have a conversation with them, says atherectomy has no place. That would be ridiculous. Nobody says that. What people want to know is, where is the space where atherectomy does help? And that's what this trial is all about, giving you that answer as a community, specifically for laser atherectomy.
Yeah. Okay. It's like the A word in PAD, I guess. The A, it's the bad word.
Mm-hmm.
The A. Well, okay. So that's below the knee. I mean, what about atherectomy above the knee? Is there also has a place been set up for atherectomy, whether it be laser or other, modalities of atherectomy for above the knee yet? Or again, is that also still a pretty big kind of blue ocean to figure out?
It's definitely still a blue ocean. There's really only one area that's for sure, FDA approved, everyone agrees, and that's in-stent stenosis. So in-stent stenosis, laser atherectomy, there's really no argument there. Everybody agrees. And it's interesting because in-stent stenosis is not going to be calcium, right? In-stent stenosis is that kind of gum that you stick underneath your table in school stuff, whatever that is.
Exactly.
And, and then we extrapolating from that, and there's no data here, this is just conversation. I'm thinking about my patients, kind of the young, 40, 50-year-old lady that comes in who has that weird, antiphospholipid stuff, that really soft plaque where the wire just flies and you're oh no, because that's just going to embolize.
Yeah.
I wonder if laser may have a role there because it's going to be similar-esque stuff, though to stuff obviously in the stents is neointimal hyperplasia, obviously, so it's a little bit different versus old clot. But I don't know. I mean, that's what we need to figure out before we move forward. But to answer your question, that is really the only place where it's for sure, get the laser.
Yeah, perfect. Yeah, that's true. I mean, the ISR laser. Do you use other forms of atherectomy for ISR, like like Rotarex or things like that? Is laser your go-to in that situation?
For me, laser is the go-to. Other stuff can be used, especially there are some of the newer ones that say you can do it in a stent. Obviously, the concern is, especially a fresh stent, you gotta, talk about like bad dreams, right? Oh my God, you don't want to blend inside the artery. There are, of course, they'll tell you like 30 days or sometimes 6 months if the stent has been in, then you can go ahead and do that. But specifically, laser is my go-to in that particular situation. And not just any laser, the recent ones, we all remember the days of the laser where like the contrast explosion, like no one wants to deal with that either, right?
Oh, yeah.
But the current lasers, specifically the one that we're talking about, doesn't have that problem. I mean, when I talk to my residents, I tell them to think of like a bullfrog sitting on a lotus flower. Like how like it just has that like pouch that comes out and goes in.
Yeah.
That's the same idea.
Like
so it's controlled. It's not this like blast. So you can shoot contrast without having to worry about it anymore with this type.
Okay. So yeah, before we get into the weeds, we actually also had a really nice conversation kind of talking about different schools of thought on atherectomy. Yeah, we just touched based on, okay, atherectomy has this like negative connotation because of overuse. But what about people's experience with atherectomy? Like when I started my job, it's true, 10 years ago, my partners necessarily didn't want to do atherectomy, maybe due to time or their experience. Like why is there just such a heterogeneous physician group out there where people are using it and not using it? Where did that come from?
That's a great question. So, that's actually, you have to take a step back to really answer that. And that's not specific to atherectomy. That's a problem that we as a community have with peripheral artery disease in general. Unlike the aortic world or even the carotid world, that has very specific kind of national metrics about what's acceptable. And, for everybody's sort of like protocolized to some extent. PAD is the Wild West. That's the one area where you can do what you want, I can do what I want. And there's really, let's pretend that at the end of the day, you have a great outcome, I have a negative outcome in terms of the fact that the patient goes on to get amputated. No one's coming for me. I don't even know I did something wrong. Like, it's just like, this is what I know and this is what I did. And so we are trying, as a community to kind of personalize care and sort of figure out, but that the PAD patient itself is such a heterogeneous mix, as to how they end up in negative positions that we need to do a better job on the science. I mean, back to what we're talking about today, a better job on the science, because we've sort of jumped that piece and moved right into action. So what's happening in our community in PAD is, companies come out with all this stuff and they're like, use it. It's good on plaque, but good on plaque doesn't translate to, in this particular patient, will actually save their leg. Now, the FDA is starting to force some of that and saying, we want to know about the wounds, we want to know about the amp rate, we want to know about amp-free survival. And so the reason that we have such heterogeneity in the way that we all treat is because ultimately what we are doing is just what our fathers and mothers are doing. Like, I trained at Stanford. This is what Dr. Lee did. This is what Dr. Chandra did. It worked for them. And now I, as a fresh grad at Mass General, I'm going to do what I'm comfortable with, which is what they showed me. And then once I kind of, if I've got the personality type to want to do more and innovate more, I might go to a company and say, let me try this out, let me try that out. But a lot of people are like, this is what I do. And then the evolution, but then the problem with that is then they train their residents to do what they did. And they go out to, University of Florida and keep doing that. And so then you end up doing something that's not necessarily evidence-based, but just what your boss did. And that is why we have such problems. But then, that in and of itself is not the real issue. The ultimate real issue is that now a patient comes to hospital X, and if it's the cardiologist that's treating them, they get one line of treatment. If IR is treating them, different line of treatment. If vascular surgery, different line of treatment. And it can range from amputation all the way through like 10 surgeries to keep their leg attached. And that's not okay. And that's what we need to stop as a community, I think.
That's, I have to say, I've never heard it explained like this. You're spot on. I mean, the range, it's. I've never thought about, just coming back from how we're trained and how it's so just the devices were all out there. You use what you want, and people get comfortable with what they like. And then that just kind of gets passed down. And really, that's kind of what's brought us here today. Yeah, you're right. My patient can go to the hospital 2 miles away and they'll get amputated. And then in our hospital, it'll be a totally different, approach. And how do you, now that we're already at the state, are we like effed? Like, are we already like, is that our, how do we now kind of get that control and cohesiveness back? What are some things we can do?
I think the number one thing is we have to get involved a little bit with the government side of things. And what I mean by that is PAD and critical limb-threatening ischemia is a major, major cost to our healthcare system, and is going to increase with the number of patients who are elderly and with diabetes coming down the pike. And if we don't sort this out on a national level and have these metrics in place, and what the beauty of it is that we don't have to invent this. This has been done already. If you look at cancer, so you look at what happened in the 1970s, right? So in the 70s, Nixon, of all people, so Richard Nixon, he knew that kind of the thing that was kind of pissing off the American public in the healthcare world was cancer. So he goes to the NIH and dumps a bunch of money into it and says, figure out cancer, big quote, figure out cancer. And the scientists start to work on it. And now what they did back then now has created, these medications that today, like let's say me and, your sister both get a lump in our breast. We go to a doctor. It doesn't matter if I'm in the middle of Missouri or I'm at Mass General. The protocol is the same. We will get a biopsy. They will tell us what the markers are. And then bang, I can go on the National, Cancer website, and right there will be what my chemo is going to be because of what I have. And so we, as in PAD, ironic, as you know, PAD kills more people than the top 3 cancers combined. So we absolutely have the need to focus down on that. And that's where I think we need to really focus. We need to say, let's go back to the science and build up again instead of trying to solve things out here blindly. So it's not going to be, Sabeen and Dua. It's going to have to involve the NIH, researchers, calcium. I have a colleague who works down in Texas, Dr. Trisha Roy, a good friend of mine. She's wonderful. She's a Methodist. She studies plaque. And she told me, just in her world, there are 10 different types of plaque and how devices work on them,
Yeah.
So, you know what? Laser atherectomy might be amazing for speckled plaque, might be garbage for full calcium. We don't know. But we need to sort that out before we can jump to saying laser works. Do you know what I mean? So that's what I think the solution is. And I think our generation, if people are ready to do that, we just need the investment to be able to. And that will change the game, I think.
That's very smart. I think I'll play a little devil's advocate on there. Is that part of the way we could innovate? I have a personal friend who, has this terrible GI cancer right now.
Sorry.
And they're doing the protocols that are all in the NCCN guidelines. And then there's all this new stuff out there that oncologists won't give to him because they're so ingrained in this dogma of like, it has to be this way. So almost sometimes that also minimize or limits innovation or adopting innovation. So there's just two. Then, you have these guidelines and some new device comes out. How do you get that incorporated? I guess it takes time and data.
I love that point, actually, because, it's so interesting. And that's like a microcosm for all like great societies. Everyone's like innovating and doing great things and incorporating in real time to some extent. But then we get to a point where like the processes and bureaucracy become so extreme that it limits who can be helped in this. And then you get, disparities and other issues because, if you're at MGH, maybe you can be in the trial, but, that patient in Missouri I mentioned,
that's exactly
no chance,
the issue.
right? Exactly.
Yeah.
And, that ultimately, in my opinion, the way to manage that is basically having people who understand that world and actually intelligently in real time keep reassessing. You never want to be locked in dogma. You have to say that, science is a living, breathing thing that changes. And but you also have to be careful. Like, back in the day, I've talked about this example before. When you went to buy shoes at a shoe store, you would go and you would be able, like your kids could like stick their feet into an x-ray machine at a shoe store and just keep hitting the button repeatedly and blasting themselves with radiation because it was fun and they could see the bones of their feet because nobody knew that if you, blasted and so, x-rays came out as this amazing thing, 100 and whatever years ago, but then very quickly were adopted without like the real understanding of radiation. Then we paid a price for it. Now we're sort of like back on track again, where even a pregnant woman can get 3 CT scans, safely. So I think there is a balance, and the key is that we have to ensure that there are people that have the time to really understand science and be able to integrate. And that comes back to then our healthcare system in terms of like, you can't have every single doctor working their ass off 24/7, making money for the hospital and have no focus on real science. You can't have rules in terms of like promotion and stuff where they want like quantity over quality. You know, there was a Nobel Prize winner guy who actually in his entire 10 years working only published 2 papers, but he won the Nobel Prize with those 2 papers. You know, and so I think what you're talking about is a system approach where we can integrate, but we just need to ensure that people are given the time and the grace to be able to intelligently incorporate things. The laser is a good example, actually, you know, where you think of the risk benefit. Like if I use this on a patient, if it doesn't hurt them, but it may help them, and I don't have the data, I will use it. But if you tell me, oh, you know, if you do atherectomy, you can cause all these horrible things, but we haven't studied it yet, then I will hold back. You know, and I think that's a smart way. But if you tell me, oh, it costs money, and if you use the laser, it's going to cost you more money and it may not help the patient. As a doctor, I don't care. I want to do what I think may be best for the patient in that particular time. And so I think each thing should be approached very comprehensively, and that's the way you actually integrate while not losing focus on innovation.
I think we need everyone to do this. It'll be we need everyone to do it. I mean, healthcare would become, you know, just in the peripheral vascular space would become so much more, you know, organized. Because, like you said, you're right. There's all these we have these metrics in carotids, in STEMI, and stroke, and things are very, you know, it's not the wild, wild west what we have right now. So, you know, this AMBITION trial that you're principal investigator on, I mean, how did you guys, that's pretty, ballsy to do a randomized control trial between, you know, laser, Arion laser specifically, and angioplasty alone. And I think that's a, you know, pretty interesting process. How did you decide to do that trial? And then give us a little bit of details on that too.
Of course. Thank you for asking. I mean, so, you know, the reason that we decided to do it is because we basically needed to like shit or get off the pot, to be frank. And what I mean by that is every meeting, you know, I go to, of course, my vascular meetings. I go to my cardiology meeting. I go to SIR. I have friends in all these areas. I speak at these meetings. And, you know, I'm just sick of this conversation about atherectomy. Like, do the data and answer the question, or like stop talking about it. Like, and that, I don't know, I've got a few colleagues who are like me as well, who feel the same way, because it's like the same thing over and over again. You know, somebody will come up and be like, I use it, it's amazing, look at all of my patients, look at this data, which is like, you know, either case series or like single arm interventional or something like that. And somebody invariably will come to the mic and be like, but there's no RCT. Then they start fighting about overuse. I say they because it's not, it's usually, you know, and
it's everyone.
There's clearly like an undertone. So it needs to be just put to rest. And the way that we do that, just to begin with, is we need to start somewhere. And we decided that this made the most sense because a lot of people do already use the laser. It is already FDA approved. And the clinical need right now, which is really what should drive all science, the clinical need is for something for below the knee patients. In the United States, we have a ton of stuff for above the knee. Okay, everything. Actually for above the knee. Below the knee, we have shockwave now. We have like the Serenator balloons, and we have atherectomy. Now, recently, you know, in New England Journal article, bioabsorbable stents are on the market now, but that's a treatment. That's not a prep, right? And we need to, and treatments don't work without good vessel prep. Everybody knows that too. So what are we going to do to get a nice like luminal gain that's going to not recoil, that's going to allow me to get this laminar flow for at least a year, so that the wound on this patient's foot can heal. That's the game. Because I tell people when I talk about this that the patients even of today, even from when I trained to now, just a decade ago to now, are different. People are full of calcium. You know, in the PROMISE trial, which was the DVA trial that I was a part of, up to 25% of our patients had full-blown end-stage renal disease, 50% had CKD. Like, that's the new world order. And so if we don't figure out how to deal, we can't just go excluding these patients from trials, right? We have to say like, because that's, you have to your patients. So we need something for below the knee. And instead of going in and like inventing something new, why don't we look at what we currently have and see what's best for what patients at what time? And so with that in mind, we said, let's see if laser atherectomy would be the right one to choose. And I personally think it is, because it's the one that has minimal to no embolization, minimal to no dissection. People are familiar with it. It is FDA approved. And in our vascular surgery world, we use the laser already for like other stuff. You know, when we do like fenestrated grafting and like people's hands have been on it. So technically understand it. And so POVA is really the gold standard for below the knee right now. Even unfortunately, the Saval trial, which was the drug-coated balloon trial from Boston Scientific, didn't show. But, you know, as you look at that, you think like, was it really true that it didn't show, or was it more the endpoints were not perfect? We don't know.
Sure.
So
Sure.
to that end, we wanted to design a trial where we really looked at like true clinical endpoints.
Good.
And made a trial that like, one, answered the question about atherectomy, two, gives us something that we clinically need, three, brings our community together so we stop fighting about something stupid, right? And also answer the overuse question, because now we'll know where it's good for. And four, and most importantly, be able to prep a vessel in a way that the treatment that you're going to put in actually is durable to some extent. And that's how we came up with this trial.
That's great. And then, I mean, at this point, you know, how far into the trial are you? I believe you started this year, correctly?
We just started up. We have quite a few sites, actually. And we just started up with our first randomized patient a day and a half ago.
Nice.
So, yay. Yes,
right.
so that's
we
good.
are right on the cusp of this,
Yes,
you know.
yes.
And how many you guys are hoping to enroll about 200 patients, is that right?
Yes.
Or what? Yeah. Okay.
And what we're actually doing is, so the way that we're setting it up is we're kind of doing a registry in combination with the RCT. So we have very stringent criteria. Like, we're not messing around here, because the overuse thing is big. Yes. Yes.
Okay, good.
And even the co-PI situation, you know, I'm a vascular surgeon, my colleague, interventional cardiology, on purpose, because we want to say, like, the community's coming together to answer this question for the patients. And so, you know, and he brings his knowledge about that world and what they need, and I have my knowledge about the vascular surgery world. And what happens a lot of times is, because our criteria is so stringent, and not stringent like to exclude patients to cherry pick, actually not at all. Quite the opposite.
Yeah.
We want to make it as real world as possible. So the criteria is such that like the lesion length has to be specific. And, you know, we're not saying you use it for everything. We're trying to say when you do. And so if you do have a patient that doesn't fit the criteria for the RCT, but, you know, has an SFA lesion, for example, that you want, because this is a below the knee trial, obviously, but has an SFA lesion.
Can you collect the data? Yeah, the registry.
The registry. So you will allow you to use the laser. We'll allow you to be a part of the trial, but the registry arm of it, so you get to use it. You know, everything would already be set up, so it's not going to waste a doctor's time that they consented and that they talked to the patient about it, because patients get excited and then you don't want to be like, oh yeah, we didn't because, you know, you didn't fit. So doctors, and then the registry things, will allow us to, you know, mine data and allow the world to mine data that's going to be available to figure out if they want to answer particular questions. Like maybe if you have two lesions, you know, SFA and something in the AT, like, do you have a different outcome than if, you know, who knows? So that's what the registry is for.
I love it. And then, you know, so we all know what will happen if you get a positive, you know, result. You know, if the results show benefit, we will know a very high level of evidence that specifically laser atherectomy below the knee is beneficial. If it's not beneficial, what do you think that impacts as far as below the knee intervention, above, or atherectomy in general? I know it's a little tough question, but
we think about it every day. No, I mean, you know, that's the beauty of it. That I have no fear of that at all, because if that's the whole point of this, that we designed a trial that really is to answer this question. And if it's not beneficial, it's not beneficial. Like, that's that. Then we say, well, why? Like, because, you know, the reason that money has been invested into this is because all the preliminary data, and there is tons of preliminary published data in large scale, you know, groups, has shown that this will have benefit, and enough of a benefit, because that's the other thing, right? In PAD, especially because of the cost of these devices, like, it's not good enough if it's like marginally X. It needs to be 1 or 2X better to really say this is worthwhile. And so, you know, and then to justify the cost. And so, you know, the best place that we've seen that is kind of in VAC therapy for wounds versus some of the skin substitutes. Like, yes, the skin substitute may decrease by a week your wound healing, but is it worth, you know, the thousands of dollars? And it's not. But if it decreases it by a month, sure, it's worth it. Right?
True.
And so that's the same kind of concept. We want to be clinical here. And so in this particular case, if it doesn't show that, the real question will be, well, okay, overall it didn't. Is there a subset of patients, where it helps? A particular type of plaque. Maybe in CTO, not so great, but, if you have great, like 60 to 90% stenosis, because the laser, I'm just making this up. I have no idea. But
no, totally. No,
but
this is
something like that might come out. And then we might still be able to do what we came to do, which was answer the question for what patients is their benefit. Right now, we're throwing the kitchens. We're saying everybody, everybody come through this. And that, I think that's really the cool thing about this trial, why I'm excited to be a part of it. But at the end of the day, even if this doesn't show that this made a difference, that doesn't mean atherectomy doesn't work, because remember, this is just one type of atherectomy. Maybe orbital is different, or maybe, so I think people will jump on it. If they believe something and it sticks to, it works with their bias, they'll be happy about it. But I don't actually know if it will stop people who already use it from using it. You know what I mean? Like, will it change practice? I am not sure. I think it will change practice if positive.
At least it'll change arguments when you go to these conferences, and you can have something more to have in your ammo, right? I'm sure the trial's pretty, we won't get into the very, very specifics, but it's probably pretty detailed. Does it allow, often when we do these cases, we're kind of using several different devices or something, whether it be vessel prep or another type of adjunctive technique. Does the trial allow for that, or is it very specific to a single device in a specific disease setting?
So, great question. It is very specific, because in this particular first one, we don't want any confounders. So, if you were to use shockwave and then use the laser, and then, which I do all the time, by the way, in the above knee. Who doesn't? But in this particular, we're really saying, standard of care, gold standard of care is POBA. Compared to that, if you add atherectomy with laser, do you make is it better or not? In terms of, ultimately we're saying like durability, right? Like 6 months, 12 months. It is possible that at 6 months there isn't a difference, because, that, especially in this day and age. But at 12 months, again, because there's data published, and we all know this anecdotally too, that if a diabetic patient has a wound, it takes approximately 200 to 300 days for the wound to heal. With good blood flow. And you can imagine if I do a POBA on a patient and I have a great angiographic result, and then I see them in 6 months and I do their ABIs, and maybe their toe pressure is like 5 points lower than it was before, I won't think much of it, especially if the patient doesn't have symptoms. But then 200 days later, the wound may not have progressed towards healing. In fact, it might regress. And what that probably means is that there was recoil at some point, and I don't have enough blood flow getting to the wound, and it never makes it. And then it gets infected, and then it has osteo, and then they get their amp. Yeah. And so the point of this is I'm sure in the beginning, angiographically everything will be great, but the idea is with the laser, that recoil ideally is not happening, and then you get that laminar flow continuously for the whole time that you need to get the wound to heal, or to get the rest pain to go away, or whatever. And so that's the other thing, by the way, kind of cool about this. Very important. We are not including claudicants. This is limb ischemia. Yeah. No one is.
This is limb ischemia. This is tissue loss. That's right.
Tissue loss, or severe rest pain. High Rutherford, and we're doing it based on Rutherford scaling. And there's a reason for that, because again, that's not the question here. We already accept in this trial, for this trial's sake, that we are talking about people who have bad disease below the knee that is affecting them. And they're looking at amputation in the future, potentially, if nothing is done about it, type thing. And so that's the patient population included here, so that we don't, again, have, you don't want to have a huge study that has everyone in it, and then everyone they were all claudicants, because obviously that shows things, and then that's going to just be a useless study.
Yeah, you basically take in, all the comments of prior studies where they're like, okay, well, so you really kind of honed down. And kudos to, you and Aaron and the entire team of the trial to really do this. What do you foresee enrolling a total of, now you've enrolled your first patient, what's kind of an expected or hopeful target to enroll 200? and when we can get our answer, because I want to know the answer.
I like it. Now, me too. I think actually enrollment will be pretty quick. We've really selected sites that are quite diverse in what they do. We wanted to, and diverse not only in, who's performing the procedure, but also where, geographically diverse, and, hospital-based and outpatient-based, so that it's literally like what we do. Everybody, so you can't say, oh, well, all your centers were academic, so this is different, or, whatever. And we also are controlling some of the anticoagulation side of things too, so that, you don't get diversity there either, because that also has an impact.
Good.
Just trying to be really, specific. So with all that in mind, and given the number of centers, we're hoping for about a year and a half or so. We really have to get things going. I would say, if you say in the next couple of months that, things are really moving, because we're doing enrollment of sites as sites are coming up. So it's rolling enrollment.
Okay.
And so actually, to the listeners, if there's anybody out there that would like to be a part of this trial, we would welcome you. And if you just want to get in, my email and unfortunately phone number is all over the internet. So feel free to contact me and I'll put you in touch with our people. So freely.
No, that's great.
We'd love to have you.
No, totally. I mean, kind of wrapping up here is, where, people who are kind of now got their feet wet with procedures, they're exploring new devices, say they're considering getting laser or other atherectomy, or considering starting the trial or getting, what kind of advice do you have to people who's just kind of listening to this podcast right now and thinking like, oh man, like I want to get better outcomes and better treatment algorithms for my patients? I mean, what would you say to them?
Oh, I would say awesome. So do I. And let's team up and do it. And I would say, let's totally get away from kind of the slashing at each other. And, the public does not understand the difference between a vascular surgeon and interventional cardiologist. And I just had my hair done yesterday, and the lady who's doing my hair literally was like, oh, I said I'm a vascular surgeon. And she's like, cardiology. She said it. So and of course I can't. And then at the end of that, all she got from that was I do hearts and veins, which I do a little bit of veins. I don't do any hearts. So but I think we as a group need to say, let's come together. So the people out there who are listening about that, we're all on your side. And I think this next group coming up, if we don't do something about it, we are going to suffer it. We're going to be the ones getting 2 a.m. calls because what we spent 6 hours taking care of went down. Where our patients are going to be not satisfied because they're going to go through all this garbage and it's not going to last. We're the ones that are, and as you all know from doing these procedures, every time you do it, it's harder and harder and harder. So, I think a lot of us got into PAD, myself included. One of the reasons I like it so much is I like the absolution of it. With aorta, a patient comes in with an aneurysm, they don't even know they have it. Then I tell them they have this horrible thing and I fix it, but they never felt bad. With PAD, you got people who are decrepit and lives are being ruined. You fix it, their wound heals, and they get their lives back. And I want to continue to do that. But because the patients are getting sicker, it's getting harder to get to that point nowadays. And so I would say to those people, don't lose hope, join forces, and let's do it. What are we talking about? Let's do it.
I love it. Let's do it.
Let's do it.
Let's do it. Well, great. I mean, thanks. I will bring up the question. I don't know if you had time to think about it, what is, your most underrated and most overrated device in your tibial intervention? And then we'll wrap up the episode. So any thoughts, you can comment on it or not, but what do you think?
Underrated device in tibial intervention, I think I'm going to say, honestly, I'm going to say deep venous arterialization, the kick, lymph flow. And the reason I'm going to say that is because it really is in the patients that are, again, appropriate patients. That's always the name of the game. Absolutely 100%. There's data everywhere now. And there's durable data 2 years out that in the right patient, 100% it saves the legs that otherwise would have been amputated. I'm a believer anecdotally. I'm a believer from the data. I do not get paid by that company. But I'm just saying I really think, and people, kind of are coming at it for the worst of the worst, saying, oh, when the patient has a wound and we're thinking of amputation. And you shouldn't. You should actually do rest pain, in my opinion. A little bit earlier. Save that leg. That's super underrated. And, if you're not doing it, it's something to think about because it's really easy to do, actually, really easy. and something that's worth doing. And
It's funny. About DVA too. I agree. I think, right now we're doing it on such end stage disease. I think we're going to start seeing it becoming more, of course, not first line, but something you would go to and do before you're going to try like 2 hours on a nasty lateral plantar artery just to get like your balloon distally. And then you're like, okay, I'll balloon it finally, right? Instead of spending an hour just to get there, to do the hour and do the DVA and get so much more flow. We're seeing that too. We're doing, I'm in the boomerang trial with distal stantless, right? And we're just like, oh man, we should just start going to this sooner. So that's kind of what we're thinking. So that's a really good suggestion for a very underrated device that I think we're going to see big time. So now overrated, this one's a little bit more controversial. What is the most overrated device? I'll tell you mine. I think is like just like a normal scoring balloon, like a VascuTrack or UltraScore, something like that. I think those are overrated, in this day and time when we have a lot more better vessel prep. I just thought like one little wire. I think there's other ones that are better, but yeah, that was something that I was thinking about. But what is yours? So I'll make it a little bit icebreaker style.
Thank you. Well, I was just going to say POBA, just general POBA. Yep. Super overrated. There's nothing wrong with it. It had its place. There was a time when it was a god, because there was nothing else. But like, you got to move with the times. And like, maybe in conjunction, like again, in this case, for example, the trial, conjunction with something, but to make POBA, especially because, there's data about this. That guy, remember the whole trial where the guy, he did a POBA and then he waited 3 minutes and then came back and did an angiogram and then 15 minutes and came back and did an angiogram and it was like, boop, like recoiled right away. Yeah. And of course it is. Anyone with any law, of course it is.
You see it.
Of course, you see it immediately. And
you see it while you're doing the case. Well, you've treated one tibial, you're doing the work on the other, and you look at that, you're like, oh shit.
Whoopsies. Exactly. Exactly. Yeah. So, but I think, we want so bad something to work and we don't have anything else that we have. It's human nature to overrate it because either you can't sit there and do all this work and then say to yourself, man, I know this isn't going to work. You have to pump up and say, yep, I did something positive. And sure, it is better than nothing, but what your desired outcome is, and again, back to the DVA conversation, even if you can get around that pedal loop and balloon it, and it looks amazing on that angio, again, the point is like, your goal is not the angio, your goal is the wound healing. So there's no way that's going to last you. And even if it does, a lot of these patients are like 60 years old now. What are you going to do next year? What are you going to do 4 years from now? So if you can do something that's going to have that durability, and it's so interesting because that's the same phenomenon that's happened in aortic. Because in aorta now, it's not about your final angiogram, do I have a leak or not? Is this thing going to last this patient the next 35 years? Because that's how long people are living. Yeah. So those are my answers, I think, for those two things.
Those are really good answers.
Thank you.
I like it. Well, it's been awesome. Thank you. I think I really have to say again, kudos to you and Aaron and the AngioDynamics team, the whole trial. There's a lot that goes into, creating a trial. So, and then running it. And I have to say, I feel like you guys have maybe created a perfect trial here to answer this specific question, which I'm really looking forward to hearing about. Thank you for being on here and enlightening us. I really appreciate it, taking the time. And I look forward to hearing more and having you on again. So thank you.
Thank you. Such a pleasure to be here and see you again.
Thank you so much. Thanks to everyone. If you have any questions, if you want to enroll in the trial and help out this important cause, please contact Anahita or us and we can get you in touch with her, the team. So thank you so much and see you next time.
Thank you guys so much for tuning in. If you haven't already, please be sure to subscribe, follow, and rate the show. Let us know how we're doing and what we can do to improve it. We work really hard at making this a valuable resource for you, and we want to continue to do that. So give us your feedback. Lastly, tell a colleague about the show. We think they'll like it. If you have any questions or comments, direct message us at _BackTable on Instagram, LinkedIn, X, TikTok, and Blue Sky. BackTable is hosted and produced by myself, Chris Beck, and co-hosts
Ali Behetti,
Michael Barraza,
Sabeen Dhand,
and Aaron Fritz.
Our production team is led by Kieran Yannon,
Aaron Bowles,
Gabe D'Agrazio.
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang, Manisha Naganathanahali,
and Manbir Singh Sandhu.
Administrative support provided by Judy Dela Cruz.
Thanks again and see you next time.